Okay, so our next speaker is Dr. Tim Baker. He is an emergency physician and director for the Centre for Rural Emergency Medicine at Deakin University. So Tim's presentation today is Rural Emergency Departments. Where do they fit in the Victorian health system?
Thank you. Well, good afternoon. It's always good to be an acute health researcher at a public health conference, and I look forward to the day when no patients come to my emergency department because you've prevented all the illnesses. That'll be fantastic because, unlike David, I get paid by the hour, so I fully support all the things you're doing, all the important things you're doing. Although I'm sure you won't stop me for having any patients. We recently had a patient at Portland who was a fisherman who got off a long fishing trip and decided he needed to celebrate. But unfortunately he got chest pain after drinking a bottle of scotch, 3 caps of speed and 4 Viagra. So I'm not really sure what public health intervention would manage to work for him. He might be complex. I'm talking about rural emergency departments. There's certainly not all of the emergency medicine system in a rural area. There's ambulance services, there's the primary care physicians, there's local hospitals, there's retrieval services. But I thought since we're in the Centre for Rural Emergency Medicine, we really should know something about rural emergency departments. Unfortunately, we don't generally know a lot. In general, emergency departments is a concept based in the city, and it's if you watch television, you see ER, and now this terrible Code Black that show what happened in emergency departments. And when you're and not much is said about rural emergency departments at all. But there are rural emergency departments in Victoria. We divide them in a number of ways, but one of the ways would be into large regional, small rural, and sub-regional. So we wanted to know what those kind of services did. Unfortunately, no one has ever really counted these. So this is a really simple study. There's no complicated analysis. It's basically just looking and counting. But we did a chi-squared test because we felt we couldn't do nothing at all. So there's good reason to think that rural emergency departments might not see many sick patients, while they might be different. We certainly have a system now, a trauma system and other systems like a stroke system and an angioplasty system, where we say we're taking all the sickest patients, bypassing small hospitals and taking them to large centres. We also know that small hospitals have less resources, and they are given a job saying you should only treat people who are not, you should only treat minor injury and illness. So maybe they do see not many sick people or not many people at all. But then maybe they do see similar patients, because we know that rural communities often have poor health literacy, and in this setting, poor health literacy often means turning up to your GP when you've got a chainsaw wound to your leg or crushing retrosternal chest pain, and they present late, and they often don't use ambulances. And we also know that most country towns have one ambulance, so they're very reluctant to take anyone bypassing the hospital, because that leaves their community without any ambulance at all. So we'd like to know this because if they really do see sick patients, it's important, because we might have to decide what resources they need. We also need to know whether we should be concerned, because there's a feeling that when you use less resources, you get worse outcomes. So maybe we're getting worse outcomes here, and that would be something we need to know. We also want to know whether our bypass system, which is the system that we run our rural emergency system by, actually works, or is it only partially working. It also helps us work out how we train and support rural clinicians. And there's always these, a lot of rural hospitals teeter on the edge of financial stability most of the time. And so if we really want to keep them open, they have to work out whether that's really important or not. So this is how we did our counting. So we've done a previous study where we went to the smallest emergency departments and took them from writing the names of patients on rolls of paper or in big books and put them on the same computerised system as large emergency departments, as the large 39 do. So we did that for the ones in our region. And then we thought, once we had our methodology, what happens if you went to the government and found out what every other emergency department, rural or urban, did? So we went and ran our same search strategy through them. And we combined it with the number that the emergency departments have to report to government, the small one, which is just how many patients they see a year. So we found that in Victoria, there are 22 large emergency departments, 6 large regional ones like Geelong, 11 sub-regional ones like Warrnambool, Hamilton, and 45 smaller ones. And there's a huge difference in the average number of presentations. So metropolitan hospitals on average see about 46,000 people in the emergency department a year, 42 at somewhere like Geelong, 17 in the sub-regional hospitals, and down to 3,000 for the small ones. But the smaller the hospital you get, the more of them there are. So when you put them together, rural hospitals see about a third of all emergency presentations in Victoria, even though almost all the focus is on urban emergency departments. So regional ones will see about 16%, sub-regional 12%, and even the very smallest ones, like Portland or Ararat or Timboon or Colac, will see about 140,000 patients a year, about 8%. Now, what type of patients they see? So we actually ran through all 26 diagnostic groups that they use to fund emergency departments, and we took it by, made this huge data cube, but you can't tell anything really from that. So we did a Wordle from our very smallest departments to our very biggest departments. So those are the type of patients they see, and the bigger the letters, the bigger the word, the more likely they are to, that's the more of those patients they see. Can you work out which is the biggest hospital and which is the smallest hospital? You think the smallest one's up the top? Yeah, so I think you see that they see basically the same kind of things, but to slightly different proportions. So certainly the top 5 categories for each one are the same. So digestive illness, circulatory illness, respiratory illness, and injury are the top for every class of emergency department in Victoria, rural and urban. But urban ones see a bit more multi-trauma, a little bit less minor trauma. And of the acute things, all of them see the same ones as well. The major acute things at all emergency departments, from Timboon to the Alfred, are circulatory problems like heart attacks, respiratory problems like severe asthma and pneumonia, and neurological problems like strokes and head injuries. This is the acuity of patients, which are across all those different sizes. So we give them categories, whether they're 1 to 5. From 1 need to be seen urgently to 5 you can wait up to 2 hours. You can see that you can hardly see the category 1. So really, emergency department is really not a really good name for emergency departments of any size. It really should be the vague illness, but one of us might die today department. And you can see that doesn't really vary depending on where you are. That the smaller you go, slightly less acute patients, but there's still a big lot of, I don't really know what's wrong with you, doesn't matter where you work. So, and we also know that the ambulance, which takes about a quarter of patients to large hospitals, still is bringing patients to regional and sub-regional hospitals. Even the very small hospitals will get about 1/10 of their work from the ambulance service when the ambulance doesn't want to go somewhere else, or maybe they think it is appropriate for that small hospital. And when they go, this is not as good a graph, but green is the people who get sent home, and pink is the people who get admitted, and blue is the people who get transferred of those different acuity categories, triage category 1 to 5. So most people go home. Doesn't matter which hospital you are, small or big. A small number of people get admitted, and the very smallest hospitals, the main difference with them is that lots of those people get transferred to be admitted. So they have a higher transfer rate. So our key findings were rural and regional emergency departments see more than a third of emergencies in Victoria. They have a similar type of diagnosis, certainly a similar ranking of diagnosis. That our assumptions about really sick patients, that the small ones see less, is probably true, but the magnitude of that is actually not very big. So they do see less acute patients, but not that much less. And what I didn't mention on the way through is within each group there's sort of a lot of variability. So some hospitals see more acute or less acute. And the ambulance, our bypass in theory is that all sick patients will go directly to large emergency departments, but in reality it's not quite like that. So we've got another few steps that we'd like to do with this. We've got access now to all of Australia's data, so we're going to run it through the 6 million emergency presentations to have the same thing for all of Australia, which hasn't been done before. We'd like to continue our local database of the really small hospitals, because that can be useful for lots of people doing lots of research. And we've used it to advocate, including to get the quality standards for emergency departments to include all the hospital-based ones as well. And we'd like to use it to encourage small emergency departments, that they are important. And so you can see, if you can tell the difference between the the real health workers and the people who are just pretending.